Very good morning, and I will be touching upon the non-surgical management of acute hydrops and management options post-resolution of the hydrops. So, this is how I will go about. I will be talking first the medical management, then we'll talk about the various visual rehabilitative procedures, which includes penetrating keratoplasty and deep anterior lamellar keratoplasty, and subsequently we'll talk a little bit about the contact lenses. So basically, we need to understand first as to how big is the problem. So we know that corneal hydrops, it's around 2 to almost close to 3% of patients of with keratoconus are likely to get hydrops with a mean age of around 25 years and male preponderance. The risk factors which Dr. Purvasha also talked about, so is like the earlier the diagnosis is made, the steeper the keratometry value, poorer vision at the time of diagnosis, and severe allergic eye disease with eye rubbing. So, I will take you through two different clinical scenarios. The first clinical scenario of a 13-year-old female who presented to us with sudden onset diminution of vision, and this was the first time she presented to us with this clinical picture. So, on examination, we noted that there was a localized central corneal edema, and there were multiple cysts which we could appreciate here. And on a slit lamp examination, we noted that there was intrastromal fluid clefts, and which was even seen in the anterior segment OCT imaging. So at this point in time, we started the patient on topical lubricants. We started her on topical antibiotics to prevent secondary infection. We started her on cycloplegics to relieve her of her pain because of cyclospasm, hypertonic saline to help draw fluid out of the corneal stroma, and we also started on anti-glaucoma medication so that we can lessen the hydrodynamic force on the posterior surface of the cornea. And of course, to decrease the inflammation, we also added topical steroids. And but we suggested her for intracameral gas injection and compression sutures. However, the patient's parents were not ready for it, and they lost to follow up, and subsequently they were on these medications, and finally she came back to us at the end of 1 month when we noticed that there was this very nicely scarred cornea. The scar was off visual axis, and on anterior segment OCT imaging, we saw that the cornea was very much compact and there were scars. Now, taking you to the second clinical scenario again, this is a 6-year-old boy who had severe allergic eye disease and had again a history of sudden onset diminution of vision. So we noted that on clinical examination that there was again localized corneal edema, and we can again see that there are cystic areas. On slit examination, we noticed that there were intrastromal fluid clefts, and we confirmed it even on anterior segment OCT imaging. But again, we started the patient on same medical management, and we wanted to do again intracameral gas injections. So these were the cases who defaulted actually. I mean, we advised something, and but they did not follow that, and finally he again came back to us by 1.5 months, and when he presented to us, he had a decent corneal scar, which was again little off visual axis. So in both this scenario, what we noticed that despite just being on medical management and not being surgically treated, both of them had a very nice scar. The only thing that we could see, not just these two cases, there were few other cases also which I did not include here, but we noticed that the only thing that we noticed was there was no vascularization at the end, and secondly, in the acute phase, the corneal edema was very much localized and not reaching the limbus. These were the observations that we had, and probably we will be talking a little bit more about it in the last slide. Okay, so now as we have talked about the acute phase that was managed medically, now we'll move on to the visual rehabilitative procedures, which includes penetrating keratoplasty. So definitely, as if we talk about the role of penetrating keratoplasty in keratoconus, so definitely the Australian corneal graft registry says that the graft survival rate is pretty good, and it's close to 90% by the end of 10 years and 20 and 50% by the end of 20 years. But the question here is it so for the eyes which are healed hydrops cases? Is the graft survival rate same or different? So there are studies which suggest that there is definite higher risk of endothelial rejection after doing penetrating keratoplasty in eyes that had healed hydrops. And probably the reason that they explained was the longer duration of corneal hydrops, more than 3 months, and the ocular associated ocular allergy. So though I'm not talking going to the stages of penetrating keratoplasty, because there is no difference between the two and it would be the same. So let's just moving on to the second visual rehabilitative procedure, that is deep anterior lamellar keratoplasty. So basically, the though the we know that DALC is pretty challenging, and the surgical procedure has been modified by different surgeons, that like use of big bubble, people have used hydrodelamination, people have used injecting high molecular weight viscoelastic to facilitate deep anterior lamellar keratoplasty. However, all these procedures that I have discussed though makes your work easier, but has a very high risk of developing macro perforation and could not be managed, and we cannot just manage it, and we cannot go ahead with DALC in such procedures. So these are contraindicated in this kind of surgery. So now moving on to the different procedures that have been performed on such eyes where there was heel hydrops. There was one study by Anwar et al. Where they noted that they did a pre-desmatic dissection, and how did they go about it? I will tell you in these pictures. We can see in the first picture that the authors had done a trephination almost close to 80% of the depth, and subsequently they started injecting air. The air injection was in the superficial stroma, and they wanted to induce emphysematous changes in the corneal stroma. And gradually they, with the help of dissectors and beaver blade, they kept on dissecting it. And every time, the second picture, we can see that though the dissection was not completed in the center, that was the part of heel hydrops, they left it like that, and they first completed it all around, and finally they went ahead and they dissected the part where there was a hydrops. They kept on doing this layer by layer, but after the section of the superficial keratectomy for the first time, they again hydrated the surface, they hydrated the stromal fibers, and subsequently again they induced emphysematous changes into the corneal stroma. And this procedure was kept on repeated every time, and till they reached the predesmatic layer. And once they had reached the predesmatic layer, they completed the entire thing all around, and finally they removed the superficial part which was there, exposing the predesmates over there. And there was not, and this is how the tissue looked like at the end, that there was a very small scar which was involving the deeper stroma, the deepest stroma, and the descemet's membrane. They did not reached up to the descemet's membrane, but they limited themselves to the predesmatic layer, and subsequently then they completed the DALC procedure. Now coming to the second technique that was which was recently published, Hyman, was like they call it as peripheral pneumatic dissection and scar peeling to complete the deep anterior lamellar keratoplasty in eyes with heel hydrops. So again here the procedure is not very much different. They again approached the deeper layers or the predesmatic layer by doing a layer by layer dissection. In the first picture we can see that they did a controlled trephination of the cornea, which was a partial thickness trephination. It wasn't a full thickness trephination. And then subsequently, they injected air into the anterior chamber also, and they had injected air into the superficial stroma again to bring about the emphysematous changes into the superficial corneal stroma. And gradually, they kept on dissecting. Again, the central part, the part where there was a hydrops, was left behind like that to bunch up, and finally they kept on removing different layers. And once they reached to the predesmatic layer, we can see in the extreme right, we can see that what they did at the end, they just caught hold the entire bunch, and they just tried to peel it off from both the edges of the descemet's membrane. So, and this was so meticulously done that once you are peeling off from one of the edges, and then once that is done, you just have to reverse the direction of your peeling. So this will ensure that your micro perforation is not enlarging. Anyways, we are opening up the descemet steer, so we will have to fill the anterior chamber with air so that we can continue with the procedure. But they made sure that the micro perforation is not enlarged to a macro perforation. And again, after injecting the air into the anterior chamber and subsequently using a DALC tissue, they performed the DALC, and they were about to, and they were able to do cases. Now coming to the another technique that the authors have discussed, that is the wet peeling technique of deep anterior lamellar keratoplasty with hypotonic water and blunt dissection for heel hydrops. So again here what the author did, They had first done the partial thickness trephination, and subsequently with the blunt iris spatula, they kept on dissecting into the anterior stroma, and they kept on removing the superficial stroma layer by layer. And every time they used to remove that, again they used to hydrate the base of the stroma with the hypotonic solution or hypotonic water, and that resulted in swelling of the residual stromal bed. And subsequently they performed it the same way till they reached the predesmatic layer. And these are the in the extreme right we can see the outcomes over 2 years, where they had shown that the size of the scar had significantly reduced and the visual acuity were almost comparable to a penetrating keratoplasty. Yes, it is said that when you are performing a deep anterior lamellar keratoplasty, where you should anticipate that okay, the surgical, your surgery might require a conversion to a PK. So you should bear that in mind. Whenever there is a very steep cornea, you are operating on say more than 60. It's very likely that you might encounter such case. So always keep a backup tissue when you are performing a DALC. So there are different studies which says that how to go about when there is a case of heel hydrops. So basically, to summarize, if I say, all of them have talked about the layer by layer dissection, and all of them have said that that performing a big bubble technique would be a challenging condition. One study that was Ramamurthy and Ramesh, in rest of the studies, they said that you can go about and reach up to the predesmatic layer by layer dissection, and they had left behind the residual scar over there. However, in a study by Ramamurthy and Ramesh, what they did, they went right up to the predesmatic layer, and then they punched out the central descemet's membrane and the scar area along with the residual stromal tissue, and then finally they placed the DALC tissue over that, and then they sutured it. Now, coming to the third visual rehabilitative modality, that is the use of contact lens. So, I won't be taking much time because we know that as such, the when the keratoconus is severe, the corneal apex becomes very much steeper, and it becomes very difficult to fit a contact lens, and it's a cumbersome and challenging task. However, when there is a resolved hydrops, what exactly happens? It to some extent makes the cornea much flatter, and this is somewhat, if the scar is not in the visual axis, can have a good fitting of the contact lens also. So basically, RGP contact lens is something which we should always try, and preferably a tri curve or more peripheral curve if it's there. That would be said to be better. Rose K contact lenses are the multi-curve lenses which will have a smaller optical zone, and we usually see that in more than 90% of the cases we can fit such patients who have their who I mean in whom there was a heel hydrops. We can fit them with Rose K contact lens in almost close to 90% of the patients, provided again the scar is not involving the visual axis. And Rose K2 XL semi-scleral contact lens, they are said to improve visual acuity as well as comfort, because at times if the patient is not very much okay with the Rose K contact lens, so we can go for Rose K K2 XL semi-scleral contact lenses. Yes. Now, once obviously there is always an issue of comfort, so we can always try a piggyback lens in such patients where there is a corneal scar. So there is a tendency. So how do we do such kind of fitting? So first we go for a say now the corneal curvature is little bit flatter compared to what it was. So we will first go ahead and try fitting a soft contact lens, and once we are sure as to the patient has a very nice fit with soft contact lens, we can just go ahead and place and accordingly we will do a topography now with soft contact lenses in place. Now the topography that we will have, and based on that we will decide the base curve of the RGP lenses. Now we have an RGP lenses that we have already fitted over the soft contact lens. We do over refraction over that, and subsequently we add up those power to the final RGP lenses that we have. So this is how your comfort post hydrops is increased in such patients. As already discussed just now, that scleral contact lenses are the contact lenses which are now considered to be one of the best lenses, because the visual acuity in patients can be improved to near normal levels also. And pros is definitely because it gives you a very acceptable fit, and adequate, because there is an adequate clearance, there is no touch with no air bubble in the fluid, and there is no, usually you should also check while fitting such that there should not be any impingement of the vessels, conjunctival vessels. So to summarize, if there is a localized corneal hydrops which is not reaching the limbus, it's likely that it will heal without vascularization. So even a medical management can work in such patients. And DALC over PK is a viable option with benefits of being less immunogenic, and equal visual outcomes as compared to penetrating keratoplasty. Thank you.
Nice presentation. Yeah. Very nice presentation, Prabhakar.
Thank you,
Prabhakar,
ma'am.
you one slide you mentioned about there's a literature and like the eyes which had a keratoplasty post hydrops,
Yeah.
they had a higher risk of rejection. Did
Yeah.
I? Yeah. So what was the reason cited for that?
So they said that if the first thing was they planned the surgery, the hydrop stayed there for a very long time, say more than 3 months, and this is in cases where there was a diffuse hydrops.